We're going to just maybe jump into an earlier live case that, if you all were here this morning, the rotablator case with the no reflow and the lithics, we're going to go there very shortly before we start the last live case. Again, want to invite the rest of the panel to join us here. And again, thank everyone for staying with us to the very last live case for Sing Live 2026. As usual, you will be able to enter questions into the chat that will shortly appear and on the sides on Vivox. Okay, we'll just give the team a moment to bring up the when they're ready to go to the last. Yeah, great. Hi, Teik. Hi, Seong. We can and Chi Yang. We can see you on screen. Are you ready to go live and share with us the case?
Yeah, good morning, KK. Good morning, panelists, Prof. Lim and Chi Yang.
Yeah, morning. But before we go, maybe we can introduce the panelists first.
Sure.
KK is with us here, but also Madeline Su, who was our fellow last year here from Philippines. Eric, you all know him very well. And is not here, right? Yeah. Chocho from Myanmar, also our former fellow. Now I think he's running the cath lab at one of the major hospitals in Yangon. Adrian is a fantastic guy, been helping us very long from NUH, the chief there in Swee Chun, a very old friend of ours, one of the early pioneers of PCI, and Upul from Sri Lanka. So I think without further ado, we can move ahead. Yi Song.
Yeah, Chi Yang would like to bring us through the case for today. Yeah, it's a very exciting one. Complex PCI, there was a theme. Yeah, Chi Yang, go ahead.
Okay, great, thanks. Thanks for the introduction of the panelists as well. So today we are going to embark on this case from the National Heart Center. So I'm just going to present the case now. So this is a 53-year-old male with risk factors of hyperlipidemia and type 2 diabetes. Of note, he had no other significant kind of other medical history, no inflammatory or autoimmune systemic diseases. He presented to us a few months ago, about half a year ago, with exertional dyspnea. At the time, an echo showed impaired LV function, about 35 to 40%, and he was therefore scheduled for an elective angiogram. So that took place in November. Showed triple vessel disease. We'll show you the images later. And he had a myocardial perfusion imaging scan, which confirmed a large prior infarct, but still with moderate ischemia in the apex, anterior, and inferior lateral walls. We brought him back for PCI in December 2025, where we addressed the left-sided lesions. The next slide shows some of his investigations. ECG, not particularly remarkable. And his laboratory findings show that he has some mild to moderate CKD. So on his angiogram, I assume you can see his angiogram here. This is the angiogram from November 2025. First shots are the cranial shots of the left, where we can see that there's an occluded diagonal branch. There's a little like ectatic or aneurysmal segment just before the D1 occlusion. The LED itself has mild to moderate disease, but nothing that requires intervention. The next shots, the caudal shots, you can see the circumflex has this perhaps strange kind of appearance in a proximal segment where there appears to be more than one track. There's a big or decent-sized OM branch that comes out of the circumflex. And we felt that this was perhaps a healed or an old dissection, maybe a spontaneous coronary artery dissection that might have occurred sometime in the past. His RCA, on the next slide, again shows very diffuse disease from the proximal to distal RCA. And again, there's this appearance in the proximal to mid segments at least, where there appears to be more than one track in the RCA. So again, possibly or likely a healed dissection that occurred in the past. There is some trickle of flow into the PDA and PL branches. There were collaterals from the left as well. So in the December procedure, Dr. Aaron Wong fixed the diagonal and the circumflex. We treated the diagonal with a drug-coated balloon, restoring flow. And for the circumflex, a stent was implanted in the proximal to mid segment with a balloon dilatation of the OM branch. Those are the final results. And if you can see the IVUS, so some images from the IVUS pulled back in the circumflex at that point, you can clearly see that there's a suggestion that there's more than one track or more than one so-called lumen inside the circumflex, again further reinforcing our suspicion that there might have been a healed dissection in the past. So today we've brought him back to address the RCA, which we're in the midst of doing now. Yeah, we can maybe hear some comments or suggestions from the panel. Thank you.
Maybe you can show us the angels today before we ask the panel.
Okay, can we switch to the angel today?
Okay, so you can see the angiogram from today. Today we have a dual access setup. So we went right radial artery, 6 French glide sheath, and the right femoral artery, 7 French sheath. The idea was that in case in the midst of wiring the RCA, we occluded antegrade flow, we could still use the contralateral injections to guide our distal wiring. We first checked the left-sided arteries. You can see that the previously treated diagonal still is patent, and it's quite a large branch. And here the circumflex, the prior stent, and again looking quite decent. This is the RCA for today. The proximal segment, the very proximal segment is relatively disease-free, but then there's a long diffuse lesion proximal to distal RCA. There's a decent-sized RV branch that comes out of the mid part of the RCA, so that will be a discussion point, how to preserve that RV branch. And in the distal bifurcation, as we see here, you have we will probably need to make sure that we can preserve both branches, PL and PDA. Okay, so that's so these are the diagnostic shots. I'll just show you the RAO. RAO at this moment not very helpful, but we took the RAO as well.
Seong, you mentioned the LVEDP and the measurement of LVEDP because the creatinine is elevated.
Yeah, so this is a patient with mild to moderate CKD, and he also has moderately impaired LV function. So in some of these CKD patients with impaired LVF, we have this CKD protocol based on the Poseidon trial. So the EDP today, pre-intervention was 17. So according to the protocol, that determines or that suggests or recommends a flow rate for our peri-procedural hydration. So according to that protocol, we've got him on 3 mils of IV saline per hour. So that's that bit about the EDP and CKD.
Thank you. So maybe we can move on to get some opinions from the panel, to see what they diagnose and propose strategies. Maybe Adrian, you've got a lot of experience with imaging. What do you think this case is, and also what is your strategy?
Yeah, I think I concur with the assessment that this might be a recanalized CTO, and I probably will probe it first with a soft tip wire, and we'll try and see if we could get a wire down into the RV branch to secure it, and another wire further down.
Do you think this is a scab, or is it just a...
It's hard to tell. It's because the patient does have cardiovascular risk factors, and he also has established disease in the left system. Not sure if this is actually scab. It's a little unusual for this man, for a male patient, and he has risk factors. It could just be common garden atherosclerosis.
Eric? What?
I think this is a great case to finish Sing Life 26. Great. Honestly, I'm a bit perplexed. I think we need to rely on the skills of the operators that they know what they're doing. It may be difficult, but maybe it will go straight away. I know there's now a big trend to use sewer wire in this kind of situation, but I haven't done it. And I'm not even sure if that's the way to go. I wonder to what extent the pre-CT would help to understand a bit better what happened, but I don't have experience. So otherwise, no comment. It will be difficult probably to get into the in the marginal branch, but it may be necessary. Yeah.
He had a myocardial infarction, but we're not sure exactly which vessel is affected. Is it the diagonal or is it the LAD? Because it's got anterior ischemia. I mean anterior wall dysfunction.
So if you look at if you run the angio again, can you run of the right, yeah? Because the part where the marginal branch is taken off is the true lumen, probably. So if you want to need to target to go down, then, well, but from this view we can't say. Maybe another view. Can't say. Really tough.
If you have questions or comments, please put up for us to answer them from the audience.
I would say that I'm not sure how the patient was in November last year. Would have been a reasonable idea to do the right first. It's a very dominant right, and obviously because it's diffusive disease, when you go in the second time in the stage procedure, you have a chance to check out the right and tidy up, because now if you go in and intervene on the right, which you do, you run the risk that you may do another stage procedure later on because it's a long diffuse disease.
I think at that time, probably they were looking for cases for Sing Live, and I think the operator thought that it would be something of interest, therefore reserved this one for the last day of Sing Live.
Thanks, Teik. Thanks.
I think in fairness, the circumflex was very horribly looking, and that probably is the area of ischemia. This one probably is a chronic dissection all the time there already. So I don't think that's probably the target vessel that we should fix first. So I think we hit the sub first and the diagonal. And now just bring back to sort of try to complete the procedure.
Yeah, I think the operator for the first PCI, because the diagonal was originally occluded. So after opening up, this is an opportunity to relook at the diagonal, the status of the diagonal.
The problem also here is that you don't have any imaging, invasive imaging modality to guide you if you're in the true lumen. The only thing I may assume that if you're at the level of the marginal and you still have flow, then you're probably in the true lumen.
Yeah, maybe we can show what my two colleagues have done so far.
Maybe before you show that, can I just ask how do you, maybe the panel in terms of wire selection, how would you select wire? You heard
Eric mentioned about SO 03, right?
Yeah, there was a mention of SO 03. Well, any others?
I mean, that's what people say, but I haven't done it.
So we decided to use a polymer jacket with the hydrophilic guide wire, a workhorse guide wire to try this first. I think, Go and Jin, just selected the Seong Black, mounted on a microcatheter.
Yeah, so maybe Seong can
So
describe this.
we started a bit earlier. So this is the Seong Black on a 5-cross microcatheter. This is the initial wiring. We save step by step to show how we progress. So as you can see, if wire went down, but it doesn't feel very right. I have to rechannel it, and as you can see, sometimes you just zoom down and you know that you're more or less in the safer territory. Again, we have to redirect it again before it actually goes down. Along the way, it gets hit a lot of speed bumps, a lot of, and as you can see here, it went all the way down to the distal RCA. And this is
But there's a
still,
risk that using hydrophilic wires, you can easily enter false lumen.
yes, that's true,
Yeah.
Paul. Yes.
Yeah,
yes,
but
definitely
so
that-
this one is
that
a softer tip one, yeah, less than a gram tip load.
Okay, so we hit the major speed bump here, right at the distal RCA. As you can see, the wire tracking is a little bit dubious, and we're not really very sure at this point in time. So it took us quite a while, multiple attempts, multiple angles. Doesn't look right. And as you can see from this angle, it's not in the AV groove anymore.
But didn't you have a contralateral?
The contralateral doesn't go so far down, and hardly can see the AV groove at all. At most, you see a bit of the PDA from the contralateral left side. Okay, so trying to feel our way through here, and bear with us for a while. I think one of these was this was the most promising shot that we have. Yes. So at this point,
looks
yeah.
like.
So Yu Seong, that was a Seong black.
Yeah, it was Seong black all the way.
On a microcatheter, yeah.
So we try to push the IVUS down. This is the inside the LifeTech IVUS from Biosensors. The IVUS, however, couldn't track further, and at most it reached this proximal RCA, and the guide got kicked back. So we have not much of a choice but to use a small balloon, 1.5, and try to dilate our way up to make some space so that the IVUS can go down. And yes, and the IVUS did go down. So at this point, maybe you want to show the IVUS, Chiang?
Hiwa, do you have experience doing this kind of scat-like case?
It's not common to see this kind of blockage in the cath lab. I mean, sometimes the problem is you're not sure whether your wire entered into the false lumen, and then you get resistance. And then usually I try not to try too hard in this kind of cases because I may make things worse and the flow will get compromised. Yeah, but if it is a scat patient, I think they may heal. So sometimes we just stop and aim for preservation of flow.
Is it reasonable to suggest for those people starting off, choose your favorite wire, the one that you used to, as soft as you can? But I think the feel going on is very important, isn't it? If the catheter kicks back or it doesn't pass and it clings, you must feel it. Don't try something new. Choose your favorite wire, the softest you have.
Yeah, but I mean, in my mind, hydrophilic wires don't give you feel. See? It's easy to slip down, but so if you're in the false lumen, that's it, you go through the false lumen. Maybe Chiang, you want to go ahead with show us?
Yeah. Yeah. Okay. So as Yu Seong mentioned, this is the Inside LifeTech True Vision IVUS system. This is the from the RCA, obviously. Yeah, I'm going to start proximal to distal, so everyone's a bit more orientated. So here we are in the guide catheter and the ostium of the RCA. All right. So this is the very proximal part of the RCA, about 3-5 in size and relatively disease-free. As we go a bit more into the RCA, we start to have this appearance where there appears to be another lumen. Yep. So our catheter and wire and one appear to be one lumen. There's another lumen parallel to it. So obviously at this point it's not possible to know which is the original true lumen, but perhaps not so important at this point also. Yeah, everything seems to be within the vessel itself. We see some branches coming in, and one way to tell whether you're in a true lumen is whether these branches join in with where your IVUS catheter or where your wire is. A bit hard to tell. There seems to be a little bit of plaque in between where this vessel joins into the vessel and where the IVUS catheter is. So that was a small branch anyway, so not so important perhaps. We're moving a little bit more distally now. I think this is we think this is where the RV branch joins in. And at this point, perhaps it doesn't quite join into the same space as where our IVUS catheter is. Yeah, even though when we wired it, when Yu Seong wired it, he actually wired the RV branch first, pulled it back slightly, and redirected it into the mid to distal RCA. But it doesn't seem to be in the same, doesn't seem to join on IVUS. Nonetheless, we go more distally. There's a bit of a negative remodeling here, where the vessel appears to be slightly smaller than the proximal and distal segments. here as well. Then it gets a little bit larger again here. So this was the pullback. This was from distal RCA. So at this point, we hadn't crossed the distal RCA bifurcation yet. We further pre-dilated with the 1.5 more distally beyond the bifurcation and repeated the IVUS run. So this is the IVUS run from the PL now. So I'll start from distal to proximal. So this is in the PL branch. We are in the vessel. And somewhere around here, where I've bookmarked, is where the PDA branches off. So at least at this point, at the distal bifurcation, the PDA and PL appear to be in the same space. Yeah. So most likely, we were able to re-enter the distal RCA before in the true lumen. Yeah, and the bifurcation of the PDA and PL is preserved. So hopefully that will make keeping the PDA patent easier later on. Okay. And it's just a lot of plaque in the rest of the RCA, mostly fibrotic plaque, a little bit of some speckles of calcium here and there, as you can see, but otherwise it's mainly fibrous, fibrotic kind of plaque. Yeah. Okay, so that's where we are. I think proximally, obviously, we're in the right place, and distally it appears in the PL branch that we are in the true lumen, yeah, that's the findings from IVUS.
So what's the operator's strategy now? What do you all plan to do?
Okay, Prof, so we are quite confident that majority of the time is in the RCA. So there is the branches now that we are a bit stuck because it proved to be not so easy to wire down the branches. The RV marginal was proved to be very difficult to re-enter again. And right now, maybe we should try to wire into the PDA instead.
What is this other wire, Seong?
Oh yeah, sorry. This is the dual lumen Crusade R with Fuder XTA wire.
Get the workhorse guide wire.
Maybe just to ask Giorgio, would you try to wire the RV branch first, or?
In this case, so the first wire easily cross into the distal RCA. So if the first wire cannot cross easily into the distal RCA, we will try the RV branch first and use the dual lumen catheter to recross again into the distal RCA. But in this case, I think it's optional to do the RV branch wiring. Yes.
And maybe just to ask Upul, if we can't wire the RV branch, would you still balloon?
Well, if you tried all our options and failed, I think we have to go ahead. And perhaps using some scoring or cutting around that area, we may be able to connect the lumens so we can preserve both the RV branch and keep it, the lumen open for the main RCA as well.
Yes, I think on the island it looks like there's a lot of half there and here and there, we're in and out a bit. I would just go and do my job, I think.
Excellent.
Adrian? Yeah.
I think the finding so far has established that the distal wire is in the true lumen into the RPL, and we could also see the RPDA. I think the uncertainty now is trying to rewire the RV branch, which is a huge vessel. I think the good news also is that the wire is pretty much within the structure of the RCA. So
1.5.
I think even if they are not able to rewire the RV branch, I personally would use like a scoring balloon to establish the track, and then there would be a good chance then to re-enter into the RV branch.
Yeah, in fact, I was going to suggest something like a cutting balloon just to cut through everything. But I noticed on your opening shots that the segment beyond in the RPAV was pretty clean looking. But in your more recent shots, the RPAV appeared to be more narrowed. So I was a bit worried, but I couldn't remember whether I saw the right thing. If time permits, could you show us the before RPAV and a bifurcation and AP shot, and then the most recent AP cranial shot, if you have time.
Because it looks like before the bifurcation at the distal, the rest of the vessel was quite good beyond the bifurcation. Before the bifurcation, it was a bit messy.
I just pulled Dr. Bimpech from Bangkok because I know he's a true IBIS expert, and he's giving us some teaching. Bimpech, do you want to speak in the microphone? Then I do it for you, okay? Because he thinks that it's potentially rectalized thrombus because the other lumen is in the plaque and it's not the media is around. You see that would go with the previous unstable event on the right.
Okay, maybe.
I don't know. To me, I think this is quite a classical case of a SCAT type 1, very nice tear all the way from the proximal right to the distal. So therefore, you may have some difficulty trying to cannulate any of the branches because of the dissections covering the origin of the branches.
I think from Jiang's description of the IVUS earlier, I think the RV branch between the true lumen, the wire lumen, and the origin of the RV branch, there is a plaque-like structure in between. Yeah, but then in the distal RCA and the RPDA and the AV groove, I think there is a connection with the wire lumen. Yeah, so I think after the initial ballooning, the ballooning in order to get the IVUS down, the images that we saw, there was actually a compromise of the RV branch, as you can see here. And then an attempt to go in with the workhorse guide wire. Which one is it? Run through, is it? Yeah, the run through was not successful over the double lumen catheter, and then so this one was actually with the XTA. This one also couldn't. If we look at the IVUS like that, I think we will explain. It can explain why there was difficulty unless we make some form of a cutting or scoring at that point, or using a stiff CTO, a higher tip load, so more penetrative types of the CTO wire to puncture in. Yeah, and then so there is this question of how important is this RV branch, how much time we want to try to work on it, or what should we do at the end of it? It will remain compromised. And then there is also, after difficulty getting into the RV branch, we thought that I think it is important to preserve that AV group, the RPDA. So we have this double lumen catheter, and then Seong has put the guide wire into the RPDA. So now we need to withdraw this double lumen catheter. We can either use the Kusabi trapping balloon, or in the resource constrained environment, we can use this two-step technique. The first step is, we can show this part here on the main screen. Okay, the first step is to flush it out, and then the first operator, once filling the resistance, and then now the second step is continue flushing. The second operator continued flushing. First operator will remove it just like the rapid exchange guide wire. If we don't have the trapping balloon with us, I think this is another way of removing the double lumen catheter.
But the trapping, Teik, you correct me, is only possible in 6 French.
6 French. Kusabi is for the 6 French.
Is possible.
In the double lumen catheter.
But not with all the double lumen, Some you can't.
The what? Sorry, Eric.
Some other brands you cannot do. trapping and 6 French.
This one is a special Kanika trapping balloon. Is meant for this type of 6 French and double lumen catheter. It is not possible with a balloon with the double lumen catheter. Okay, so we now have the wire in the posterolateral branch and the PDA. We have that IVUS images. Now we have also a slow flow in the RV branch. Any suggestion what to do?
Maybe you want to IVUS against Teik and see which wire is more favorable that you can use a double lumen again to try and redirect into the RV branch.
At the RV branch, I think both of them in the same lumen because the second wire was advanced over the double lumen catheter riding on the first. So yeah, maybe we can have a look at that location again, just at the origin of the RV branch.
So take in your previous angiogram that you shared with us with the double lumen catheter, maybe it was a little too distal, and you may want to redirect it from a more proximal direction.
Yeah, we tried the more proximal direction. I think earlier, I think didn't capture the thing.
I think one of the advantages that currently is because you're in the structure of the vessel and there's lots of micro channels.
Yeah.
You could perform a fenestration strategy by using cutting balloon. So that might actually result in communication of the various micro channels.
Yeah. You can see that there was difficulty in advancing this IVUS catheter down. Maybe our next step is to use a cutting balloon to dilate. I hope the cutting balloon can go down. Which scoring balloon would you, or cutting balloon would you suggest? Something a little bit smaller profile that can go down. Yeah.
Any preference? Iwan?
I think cutting balloon, you can try to fenestrate with the Wolverine cutting balloon, maybe with a small size, and then you see how it goes. But for this case, I still have my reservations because I'm not sure whether things may get worse or it get better, to be honest.
Maybe of interest to have a look at the initial IVUS again to try to understand again. So the IVUS couldn't go down, is that?
Yeah.
correct?
Now the IVUS cannot go down.
Okay.
What about a lacrosse epiter? I think it's quite deliverable and it's relatively a small size lacrosse.
Yeah. We tried this score fax trio. Not really cut too much, not that sharp, I think. But its crossability is good, but I think not so much for the fenestration.
I think one of the issues doing this kind of section is
I want to see the IVUS.
It's not easy to pass anything down, even though angiographically it doesn't look so severe. And that's why for SCAD patients, the recommendation is actually to just continue medical treatment if possible. But of course, if there's ischemia, patient having unstable angina, you might have no choice but to try to do the case.
Yeah, you want to see the original IVUS, right? Yeah, Tiang will be showing. Yeah.
Sorry, what do you want to see on the IVUS? What was the...
I think Adrian is interested in looking at the origin of the RV branch.
It would be good to have OCT, but I think in this case, because of the tears, it's quite dangerous. It may cause further dissections.
Tiang, you managed to show the...
So you see, this is the point we made before. The media is intact everywhere. You see that? So
I think that illustrates some of the challenges with this kind of case. I mean, the operators would have to be very confident of where they are, and imaging is reassuring, but we still, I'm afraid, get a bit of paranoia that we are not in the right place, and we just, maybe it's hard to appreciate. So I think it illustrates the challenge of doing these kind of cases.
So what size of scoring balloon you're using? Is it a 2.0, 2.5?
2.5. This one is a 2.5.
Sure.
Maybe you can go back to the fluoro then. Are you advancing? Sorry, we can't see.
Okay. You're done seeing the...
Maybe you can repeat the IVUS now?
Oh yeah, we haven't finished the ballooning sequence.
Okay.
Yeah, we plan to no, we are inside the RPD. Sorry.
Is the balloon going down smoothly, Yuseong?
Not really. We have the balloon our
I think
way down.
at the just a distant bifurcation. Where is the balloon?
Balloon back in back.
Okay. Actually, the balloon didn't go down very easily. Yeah.
Using the score flex.
Yeah, we thought actually maybe we may think that it is not as sharp as the Wolverine or the Apata.
And you put the balloon on which wire? The RPAV wire, the workhorse, the first one.
Actually, look like this one is in the APAV, right?
Yeah.
Yeah.
Okay.
Yeah. But we may not want to cross too much. I go low pressure here. Yeah. Because on the original IVUS, it looks like Okay. After this, we are going to run the IVUS.
So just out of curiosity, when we do this, right, do we want to take a picture before the IVUS or just do the IVUS? Is it safer? What do you all think?
Which one?
No, let's say after you've done the cutting balloon, would you take a picture first or would you IVUS first?
Okay. I think we can take a picture first. If either one is okay. I remember what you mentioned. You have some concern whether we are in the true lumen, and just to make sure that there is no perforation. So we are going to run the IVUS first. Take the angio first. Take the angio first.
I think it should be quite
I
safe.
think the main concern is whether you extend the dissection.
Yeah. Because the original IVUS showed that let's go. The original IVUS showed that I think the first wire is inside the vessel architecture. So and it was actually 3.0, most part at least 3.0.
And that looks reassuring, although I mean this is very nice.
But the RV branch is gone, right?
Yeah.
Because you see,
okay.
IVUS, yeah.
I think as
Jiang,
long as
you
you're
pull back
inside
at
the
how
vessel
many?
architecture,
Flush the catheter, please.
Okay, Jiang is going to
Can you
run this
flush the
IVUS.
catheter,
Can we show the IVUS? Okay, at 10 millimeter per second. For this particular IVUS system, at 10 millimeter per second at high speed, there is increase in the frame rate to 100 frame per second. So there is less degradation of the image quality.
yeah. But Teik, if you're going at 10 millimeter per second, you might actually miss the takeoff of the acute marginal. I would actually
Go slowly
slow
at the
that's right.
at the marginal, at the
Because
marginal.
you're going to lose the longitudinal resolution, and you will not see where the takeoff.
Agreed. I think Jiang just want to show that the image quality remains reasonable at 10 millimeter per second.
Sure, maybe you go 0.5.
Let's go back to the RV branch. Go to the LAO. Near to the RV branch. You come out a little bit. Jiang, you will set it to 0.5. Yeah. Okay.
Okay.
Want to pull back?
So it's pulling back now at 0.5.
Yeah. Want to give a running commentary, Jiang?
Sure. So we can see that the lumens is larger now that we've dilated it with the 2.5 score flex. Just waiting for branches to appear. There's a branch coming in at 7, 8 o'clock. Not sure if that's the RV branch. We might have to co-register that with Angio later. So the other benefit or the other feature of this Inside LifeTech IVUS is it does have a co-registration function, but we have not unfortunately set that up for our lab yet. Not in this lab, so we can't show that today.
Now it's proximal already, Jiang. I think we
Okay.
Yeah, maybe a manual. You want the manual? I have a look, huh?
That'll be helpful.
Yeah. Yeah. Just around that region, here I think, yeah. Then the question is whether in our initial cutting balloon, whether we should have used something smaller, just to cut around that area.
Teik, can you explain why smaller would be better?
The smaller just try to actually break the barrier between the true lumen and that entry into the RV branch without pushing too much of the plug out and obstruct the lumen. But I don't see, I don't seem to see the origin. Jiang, you think this is where it can't be
There is
so
a branch
sure,
at 7, 8 o'clock.
Yeah, 7, 8 o'clock.
Yeah. It looks like a decent sized branch, so I think it must be it.
Yeah, around
Don't
here.
see how,
You can see that there is a layer of material between. Yeah.
Maybe you can take a picture with your IVUS here, just to confirm.
Yeah. We slant it a little bit. Yeah. So at the CTO session, some of colleagues say that this RV branch, no, up a little.
Can you record the IVUS at the same time you do the injection so you can see the lumen?
Yeah, we put it stationary at this point.
It looks more proximal, right?
The origin look a little bit more proximal. Yeah. I pull it back a little bit. Maybe here. I'm not sure whether maybe here at about 8 o'clock.
But is the patient doing well? Any ECG change?
No ECG changes, no pain. Hemodynamically very stable. Then the question is whether
maybe
whether
leave it alone.
Yeah.
Maybe ask the panel. Anyone want to intervene on the RV branch? Upu?
I'd leave at this point. I mean, I'm hoping we'll be able to finish this without putting any metal across this. So if we can, I think the flow will come back.
No, I think we should just watch it and leave it alone, I think.
Everybody agree? Anyone wants to go and intervene on the RV branch? Or it looks big, but it's RV.
I wouldn't give up on it yet because it started off with TB3 flow and there's a sizable acute marginal branch. And so the question is what to do. I mean, if you're not going to intervene the RV branch, further intervention of the main vessel might actually compromise it further. Yeah, so I personally would try a bit harder. Maybe try approaching it more proximally to see if we could enter into the RV branch, because I think there's still a chance to salvage it. And I think he's well within the architecture of the vessel wall, so I would have no concerns with perforation or rupture. If anything, further scoring balloon would actually result in fenestration, and that's what you want to try and get the micro channels together into a confluent channel that maybe you can more proximally direct a wire to the RP branch.
Adrian, you are suggesting a cutting balloon instead of something that has a cutting element rather than using the guide wire.
Yeah.
Huh?
Maybe you have concerns with Wolverine being too aggressive. Lacrosse Aperta might be a consideration.
Yeah, I think like that, yeah. But both of them are okay. And Kanika also has another cutting balloon, not available in Singapore at the moment. Yeah, I think we probably just cut around there, and then the other segment, we will use the long 3O balloon for prolonged inflation, and then and we shall see. Maybe one option is if after the cutting balloon at that origin of the RV, and then a long balloon inflation to prepare the lesion. One option is DCB first, and some other time, and maybe we can come back to work on it. There's one option. Of course, if there is the other option is, but we only have a 7 French catheter. Yeah, it's difficult to have this IVUS guided penetration. Can be tried, but
maybe I ask Mandarin. Mandarin, in Philippines, do you see this kind of condition often? And what do you all do about it?
I think just at the RV brand.
Actually, there are cases of spontaneous spontaneous coronary artery dissection, but I have seen acute cases. But this is the first time probably. So, chronic scat.
Thank you.
It's around here. Yep.
Yeah. So this is a 3O and C aperta.
So like all scoring or cutting balloon, we should go up slowly, allowing the element to have time to interact with the tissue.
How many, just remind me, Teik, how many scoring elements are there for the aperta?
There are three. There are three integrated scoring elements. On aperta.
The Scoreflex also, the Scoreflex trio also has 3, right?
Scoreflex 3O has 2 integrated wire plus 1 a little bit more mobile, the workhorse wire. Yeah.
Right. And of course, the Wolverine has got 3 as well.
Yeah, Wolverine has 3 as well. Yeah.
So Teik,
Yeah.
without the marginal, is there any hemodynamic changes?
No,
or is the
don't
patient
have.
unwell?
Don't have. That's why there is this question of whether it is okay to leave this alone. I think there is a divergence of opinion. Yeah. You go up. Yeah. Okay. He is perfectly okay. So one option is if it is okay, and then we don't put any metal across it unless necessary. And then there's always an option to come back some other time if it's symptomatic.
So we had heard the possibility that this is scared, but there's also the possibility it is not scared. Does it make a difference as to whether you will use a drug-coated balloon or not? How would your strategy change depending on your confidence level that this is or not scared?
Even if it is scared, it is within the tunica media. So, but we can see that there is also tissue proliferation within this in the hilt segment. Yeah, we would like to actually keep it open. And
Maybe I get an opinion from Upu. Upu has got quite a bit of experience with drug-coated balloons. Upu, do you think we can use DCB here?
Yeah.
You mean after SCAT? Yes. I have used in acute MIs also. Not knowing on the first instance, I thought it was an proximal LAD occlusion. But young
The
chap,
proximal
so I
one
scored
to-
and used the
one to
DCB, and
a
I
little bit
sent
more
for a
like that.
CT after
Yeah.
3
More,
months.
and the distal
No
one to
plaque
cut,
disease, completely healed.
Yes.
Anecdotal evidence is
Yeah,
there.
yeah, I want to
But as
cut,
long
cut,
as the
cut,
flow
cut,
is
cut,
good
cut,
and no
they said
vessel-threatening
we want to
dissections,
use
I
the
think
proximal.
we can use the
Proximal.
DCB.
The problem is that there's dissections all over the place, so it might not get a good woman.
We will have to anticipate an ugly picture right at the beginning, but we'll have to accept it, I think.
So maybe just to push that a little bit, Swee Chun and Adrian, would you use the DCB?
Yes.
You would?
I would thought that we will spot stand if we need to, but DCB do all of it and spot stand where we think the trouble may come from.
Yeah. Adrian?
Yeah, I haven't
We
ruled out
use a trio.
a DCB yet, so still a consideration.
Okay, I know what Eric will say, but I want to hear Giorgio as well. DCB?
Yeah, let's go.
Would you?
Actually, I prefer standing.
Standing,
So
more-
I will do the standing distally, and then I try to cross the RV branch. So before the standing distally, the dissection will extend into further distally. So stand the distal segment first, and then try, and we can inject more safely. Yeah.
Okay. Ihua?
I think it all depends on the proximal segment and the flow. I think flow is important because if you're thinking of DCB, you have to DCB from all the way that whatever that you have pop up distally all the way back to proximal. So I think I will look at what the flow is and the residual stenosis. I think it's always okay to defer and bring the patient back in a few weeks' time for definitive therapy.
Madeline?
I think I would go with DCB first, Prof. Yes.
Okay. Eric? What?
I feel so lonely on the podium. But if you look at the view before the angel,
The flow is actually quite good.
Can you show the last angel?
Actually, the flow is quite good. Let's
The
show
flow is
the
back
angel.
here. Look at this.
Yeah, the flow
this
is
one
actually
here.
quite good. Yeah.
So if you look here,
so we
have-
thought we just want to prepare the lesion a little bit more while the panel continue to discuss, and we have put in. We actually further did the cutting, the scoring balloon dilatation at the proximal RCA, and then now we are using the non-compliant long 30 times 20 balloon to dilate the distal RCA. We go for a longer dilatation, for in preparation. If the angio result, post-dilatation angio result is good, then we will put the DCB because he is still quite young. He is still quite young, and we do not want to put in too much matter.
So
at this point. Yes.
So Teik, do you think you could do possible to do a OCT here now, since it's quite open? Only consideration is the CKD.
The CKD, I think Look, we already have the IVUS here already, so so OCT may not add too much info and then get some more contrast, I think.
So taking your previous angio image from the LAO projection, there seems to be a tract leading into the acute marginal branch. Would you want to attempt tracing the tract into the acute marginal branch?
This one,
that's after your scoring.
this one, yeah.
Yeah, it's quite
It's
proximal.
actually, it come off proximally. I'm not sure whether it is another recanalized channel that actually drain into the RV branch. But so if in the process of healing, that channel supply the RV branch, whereas the main RCA lumen, the true lumen, is supplied by another route. Is that okay? I think there is still some blood flow inside.
So I'm just wondering, because it's a very tenuous connection, and if you can establish a wire into your acute marginal and you have another wire in the main branch, I suppose you can consider angioplasty to just basically join the two channels together. Then you have one big, tract.
That's all. Yuzhong, you want to try this, Yuzhong?
Try it for a while.
You want to try this? Yeah.
You end up with a very long carina.
Yeah, we may end up with unless after you balloon it and then you cut it again to finish it. Yeah. Jiang is concerned that if we do that, Adrian, that there is actually a long pseudo tissue carina.
I think the question is whether that carina thing is because of this septal connection, separation between the channel into the acute marginal branch and the main vessel wall itself, right? Because it's not clear to me that there's any real concern at this point in time, because if that septal separation is because of fibrotic tissue, because previously it was occluded, and now you're just basically trying to establish a flow.
Yeah, Adrian, will you use, say, something like Gaia Next or Conquest to try to penetrate?
Since there seems to be a continuous connection, I would try like maybe an XTR if you have concerns here. An XTR might actually go down there, something soft.
Yeah.
If you look at the whole scenario since the beginning, I think you're getting a very nice result that we didn't anticipate from the beginning. The flow in the marginal is not too bad. I'm really not concerned about losing it. Basically, we have a quite nasty dissection proximal to the marginal takeoff. One option would just to be to DCB the distal part that you balloon traumatized and just secure the proximal right with a not too long stent and leave it there. That would be my solution.
I think we have left this kind of poor flow in branches before, and when we come back, they do quite well, you know. They come back again.
Yeah, that is probably the strategy that I think, we
So Teik and Yu Seong and Chiang, you know, I think that you have really got a great success. We're going to come back to you in a while. Let us quickly go over to Dr. Igarashi. I think he's finished his case and he wants to show us his final result, and then we'll come back to you as you decide what your next steps are. Dr. Igarashi, you're live.
Can you hear me?
Yes, we can hear you.
Almost I finished my procedure. Okay. From which timing I should explain my strategy?
You took us to the point where the two wires were almost meeting.
Okay, all right. So I tried reverse cut procedure because I want to protect proximal septal branch.
Yeah, somewhere here.
Around here, okay. And from this situation, not easy to cross each other because of maybe calcium. So lateral wires also go to the subintimal space and try several times. And the balloon size is 2.20 to avoid hematoma progression. And first, I started with Gaia next 3. However, too stiff and maybe migrated into the subintimal space. From such a situation, Gaia 3 is no work. So I changed to the more floppy wire, and finally, I selected polymer jacket Gladys, intermediate chip load, 3 gram, and I could so pass the CTO region successfully. Okay, and after that, after externalization, balloon dilated by 2.0 balloon. And okay, yeah. And check IBUS. We want to share this finding. Unfortunately, hematoma is progress, more distal part.
I can show the IBUS.
One reason is wire is advanced deeply. That is my mistake this time. Like this, hematoma is detected beyond the mid part of LAD. CT region like this. And just proximal of this calcium, this is distal diagonal branch on the inside of CT region. And almost inside of inside of all the plaque. And into the plaque tracking is possible. And the proximal septal branch. And the problem is proximal part of CT region is very diseased and calcified. Like this. This is a very tough region, dilated by balloon before procedure start. And the circumflex is coming like this. And ostium of circumflex is disease also So best strategy for LED is crossover stenting. However, I'm afraid some additional strategy is necessary for circumflex to avoid. My plan is only CTO region covered CT by stent and try touch DCB balloon only proximal part. Okay, that is my strategy, and I decided to put a stent and measure stent length.
Show the cache.
2.5,
Show the cache.
35 millimeter stent. DS I selected.
So just
Okay, all right. Skip. Okay, this one, and next one. And I dilated by low pressure, distal part of LED region, and injection.
Yep.
Next one. Okay, like this. So maybe because due to hematoma, distal flow is not so good, and the proximal part is not so damaged like this. I discussed with him and how to manage distal hematoma and the proximal part. Then we decided to avoid crossover stenting from left main trunk, and the DCB I selected 2.5. And the distal part is entry point of hematoma is covered, so no contrast is detected. So maybe high possibility this hematoma disappear 1 week or 2 weeks later. So no touch more. That is our decision.
Yep.
And the proximal part, I dilated by a delivered drug balloon, 2.0, 30 millimeter. And we want to show you the current situation. Okay. Are there some questions? A long journey.
Oh, fantastic case. Congratulations.
Thank you very much.
Maybe I can ask any of the panel, any comments?
Okay, let's take a picture now.
Yeah.
Okay.
Is the patient okay, Grashi?
Patient is okay, very stable. No
show the hemodynamics.
Everything okay. So I don't want to touch to circumflex. So I think it is better. Safety is very important.
Okay.
And the blood pressure is 140 and no ST change. And the third part is maybe recover, improve future.
Yeah.
And I want to finish this case. Okay.
Yeah, thank you so much for this really tough demonstration.
But very nice, interesting case, I think.
Showing us how antegrade and retrograde procedures can be done safely using the careful techniques of the Japanese doctors. Really privileged to have you here, Dr. Igarashi, again this year, showing us all these fantastic CTO retrograde cases and also farm jumping. Thank you. Let's give a big round of applause to you.
Thank you very much.
Thank you so
Next
much.
year, please show me this case, this part.
We'll try to
okay.
Get it back. Okay.
Thank you very much.
So thank you. Maybe we go back to Sutek's lab. Sutek and Seong.
Okay, so just now where we left us, we are just doing our ballooning. We do further ballooning with 3O balloon throughout the whole RCA, starting from below down and going back all the way up. And this is I'll show you our last picture, which is this one. Okay, sorry, this one.
Yeah, after dilatation, it looked like this, and there may be, it looks like there is another channel in the AV groove. Yeah, the flow is good there. Yeah, the plan now is to actually put the DCB distally. Any suggestion about what to do in the proximal? A little bit shallow cranial, a little bit shallow cranial. Let's just go to the near to the bifurcation, not too far, not too far down, not too far down.
I think it's a good suggestion to DCB, unless you remove the wire and then the dissection all comes back again. Oppo, do you have some comments?
Yeah, I mean, I was not expecting such a good result at the beginning. To be honest, I thought it will look ugly, a lot of dissections. I can see type B dissection proximally. I would really accept this result, good enough to DCB, actually. Looking good, yeah, fingers crossed.
With DCB?
Yes, absolutely, all the way up.
Teik, you heard that?
Yeah, actually, we also plan to DCB first. Then maybe subsequently, if symptomatic, we can actually have the opportunity to relook.
What is this DCB that you chose?
This is the
sequence please, 30 by 40.
Please, the 30 times 40. Yeah.
That's one of the longest there is. Yeah. So that's I think an excellent choice.
We prepare the next DCB.
You're going to DCB all the way back?
Yeah. In the clinical practice, if the patient can tolerate a longer duration of the dilatation, nowadays I tend to go a little bit longer than the 60 seconds. I'm not sure whether it makes any difference, but I remember there's our South Korean colleagues previously studied between 1 minute and 3 minutes. The clinical outcome for a much longer inflation of the DCB appear to be better compared to the 1 minute. And I just wonder any thoughts among the panelists on this duration of inflation of a DCB when patient can tolerate it hemodynamically.
So Teik, maybe we wait for you to treat the proximal lesion and then the final shots before we conclude Sing Live this year.
Yeah. Okay. Yeah. So instead of going 3 minutes, we go for just 90 seconds.
Thank you so much.
Because not many people have that hypothyroid tendency.
Did you say 3 minutes? I thought it was only for peripheral interventions.
Yeah, do we know whether the drug delivery to the tissue will be a little bit better if we leave it in contact for a little bit longer?
What about the sirolimus, what you call it, micro capsules or whatever they have that gets embedded and then remains there much longer? Do you still need that 3 minutes stuff?
I'm not sure. I think that come from the sequence, please, the brachydactyl base. Yeah.
I vaguely remember from B. Brown that they did these animal studies where they showed that 90% of the drug after 1 minute is in the tissue. That's where it comes from, yeah.
Which one?
The sequence, please.
Sequence, please, yes.
They published, so long time ago, yeah.
Your experience.
I think the recommendation is minimum is 30 seconds. I personally will, if patient can hemodynamically stable, I will hold up to about 60 seconds. So in AMI, sometimes I just minimum 30 seconds for paclitaxel. So for solution, de novo trial, I think the minimum is 30 seconds. But I think most of us will hold up to 60.
25.
Most of the drug actually will be eluted in the first 30 seconds. So we always say that you do the lesion prep. The final step is just to deliver the drug.
Yeah, I suppose if 180 seconds make no difference to patient stability, there's no harm, isn't it?
Yeah.
I think so.
Sorry. But if you 1 minute you have 90% in, if 3 minutes you have 95% in, there is decremental gain, but is it worth it? And then the other
philosophical question, Teik.
Yeah. I mean, there is scientific curiosity. The other thing is, in this long lesion, is we put 2 long DCB. Is there harm if we overlap the 2 DCB a little bit more?
Actually, I think it would be fine, and maybe an alternate drug would be okay. Would be just, but of course this is an evidence poor zone, so we don't know.
So in the bench testing, they went up to 9 micrograms per square millimeter. So no, these are all 3. So I think overlapping with 2 balloons is pretty safe, done in frequently.
Yeah. So in the clinical practice, do you tend to overlap them more? If that is the case, then theoretically the last balloon, we can actually use another 40 to overlap. And you may argue that maybe double dose, slightly more toxicity, maybe the vessel remodeling a little bit better, less chance of restenosis.
I mean, it costs the same price anyway, right? You get better value.
That's all right.
Yeah, so there are a fair bit of unknown. There's the osteum. We need to cover the osteum.
Yeah, near the osteum. Osteum is quite diseased.
Yeah, yeah. So I think we will need to take a little bit of picture, make sure that we cover the osteum. Yeah. You want to come back slightly, or
It should be fine.
Should be okay? Okay?
Okay.
I guess the very ostium is okay, so I think you just landed it perfectly there.
So this one is a 3.5. So we have 3.0, 3.0, and 3.5.
After this, Teik, could you take a final picture so that we are sort of slightly over time? But
Yes. So sorry. Certainly, KK, in this setting, we will not inflate the balloon for 3 minutes. And the other thing I would like to ask for opinion is whether after deflating, whether you will just do an oscillating inflation, whatever drug that is up there may still be delivered into the blood vessel. Does that make sense?
I think I don't know. It might be good to ask the companies, what the benchtop testing shows. I must say I'm not too sure.
Because there is another drug, coated balloon, that mentioned that after the first inflation, 2/3 of the medicine is delivered, and then the second inflation, another 15% might be delivered. Yeah.
For the first time, Teik, the ST is up, I see.
Yes,
the patient
yes.
okay?
Yep. Yeah.
But
The
it's coming
patient is
down
okay.
now, yeah?
Yes.
It's coming down.
Yeah. We are giving the nitro, and we'll take a picture.
Ready?
Yeah. Okay. Is it acceptable?
I think it looks good. There's a proximal mid segment that has some disease, but honestly, I think we just let it heal. And I don't know, what does the panel think? You guys happy with this?
Yeah, I think it looks great, Teik.
Yeah.
Yeah.
But Eric wants another view. Ario?
Yes.
Ario, please.
You want to actually manually rotate. Manually rotate.
Yeah, I think just short injection.
When you feel, if we see that there is no compromise, just remove the wire. Okay, manually rotate. Okay, come rotate. Yeah, rotate. Yeah. So look like there may be another channel in the AV groove from this rotational angio. Yeah, but we are okay.
It looks like a superb result, Teik, Seong, and Chiang. Yeah. Congratulations.
Thank you for the opportunity to share this case. And the RV branch, the flow is still quite reasonable, so we shall just leave it. Patient has no symptom. Okay.
Okay, thank you all very much.
Thank you.
Congratulations for this nice, different kind of case at the last session of Sing Live this year. I'd like to take this opportunity to thank all the panelists here and staying for the end of this live transmission. Thank you all for staying behind at this networking lunch for you up to about 1 p.m. So please help yourself. Yeah, we'll see you. Bye. Thank you all. Bye.
Thank you, everyone.